We described the pharmacokinetic and pharmacodynamic properties of anti-infective agents used for opportunistic infections. We explained the pathophysiology and clinical presentations of common opportunistic infections. And we looked at patients living with HIV to assess the need for opportunistic infection primary prophylaxis. Now, given a patient living with HIV who is infected with an opportunistic infection, let's recommend guideline-concordant treatment. A fundamental part of treatment of opportunistic infection is initiation of ART if the patients are not already on it. For PCP, it is important for patients to be started on ART, if possible, within 2 weeks of diagnosis of PCP. Now, it's important to note that aerosolized pentamidine should not be used for treatment of PCP because it has limited efficacy and it is associated with more frequent relapses. And whenever possible, patients should be tested for glucose 6-phosphate dehydrogenase deficiency before primaquine or dapsone is administered. Treatment of PCP is based on severity of infection. So mild to moderate severity, which can be treated with oral treatments, they do not require IV administration of drugs, is defined as either PaO2 of at least 70 millimeter of mercury at room air. PaO2 is partial pressure of arterial oxygen, or PaO2 gradient less than 35 millimeter of mercury, and so the capital A is for alveolar oxygen, whereas the lower A is for arterial. The preferred treatment for PCP, mild to moderate PCP, is Bactrim. So either dosing by body weight, so 15 to 20 milligram per kilogram per day. So that's a total daily dose that should be divided in 3 doses, which translates into roughly 5 to 7 milligram per kilo per dose, or a fixed dose of 2 double strength tablets 3 times a day. So those are preferred. And alternative agents for people who cannot tolerate Bactrim is dapsone plus trimethoprim component, or primaquine plus clindamycin combination, or atovaquone suspension. Now, atovaquone is less effective compared to the other agents listed here, and treatment should be for 21 days. For moderate to severe infection, patients must receive IV treatments initially if they can, and the definition is PaO2 of less than 70 on room air, or a gradient of greater than 35 millimeter mercury. And the treatment again is trimsulfa at 15 to 20 milligram per kilogram per day, divided into 3 to 4 doses, and this should be administered IV. And patients may switch to PO after clinical improvement. And again, treatment is for 21 days. Patients who cannot tolerate trimsulfa, alternative regimens for them includes primaquine, which is actually only available as PO, so we may have no choice but to give them primaquine PO, but the clindamycin part can be IV. Or if oral option is not, the patient cannot orally absorb medications, pentamidine IV is available as an alternative. And very important for patients with moderate to severe is the adjunctive treatment of prednisone. This is associated with reduced mortality. So these patients who have moderate to severe PCP are at increased risk of dying. So prednisone, which can be given over the 21 days as a taper. So the first 5 days would be 40 milligram twice a day, and then the next 5 days is 40 milligram once a day, and then the final days of day 11 through 21 is 20 milligram daily. Now, if the patient cannot take orally, we can use IV methylprednisolone that can be given as 80% of the prednisone dose, so we can adjust from there. Secondary prophylaxis for PCP should be started immediately upon completion of the 21 days of treatment, and should continue until the CD4 count is more than 200 for at least 3 months. Or if the CD4 is between 100 and 200, the RNA must be undetectable for at least 3 to 6 months. Now, for secondary prophylaxis, again, the preferred agent is trimsulfa, either double strength or single strength. Alternatives include lower doses of trimsulfa, dapsone, pyrimethamine, leucovorin, atovaquone, and of course, there are alternatives that do not cover toxoplasmosis in case the patient needs toxoplasmosis coverage. That's important to consider. Let's take a look at treatment of toxoplasma encephalitis. So preferred agent is pyrimethamine sulfadiazine plus leucovorin, and also we have, this is new in this guidelines, trimsulfa is also considered first line. There is significantly more evidence with pyrimethamine and sulfadiazine. That's why that's listed first, but trimsulfa is also has made it to be preferred. Alternative agents include pyrimethamine and clindamycin, or some combinations of atovaquone with pyrimethamine or sulfadiazine, or atovaquone monotherapy. Treatment should be for at least 6 weeks, and of course longer duration if clinical or radiologic disease is extensive or response is incomplete at 6 weeks. And again, upon completion of treatment, secondary prophylaxis should initiate. In this case, for toxoplasma, we call it chronic maintenance therapy, which essentially the agents are similar. So preferred is pyrimethamine sulfadiazine plus leucovorin, or trimsulfa, and we have some alternative regimens. Now, chronic maintenance should continue until the patient is asymptomatic and CD4 count is more than 200 for at least 6 months. For treatment of disseminated MAC, of course, ART should be started as soon as possible after diagnosing MAC, preferably at the same time as initiating the antimycobacterial therapy. At least 2 drugs should be used in combination when treating mycobacterial infections. And we should test for susceptibility to clarithromycin and azithromycin. So here are the recommendations. So again, macrolides are preferred agents for MAC, including for treatment, but in combination with ethambutol. So clarithromycin has the most evidence with it. So even though it has significant drug interactions and strong QTc prolongation, clarithromycin, if the patients can tolerate it, should be started BID. Along with ethambutol. Alternatively, azithromycin, in addition to ethambutol, can be considered preferred. Alternatively, a third or a fourth agent can be added to this combination of macrolide and ethambutol. Many patients, especially if the patient has more severe infections, as well as if there is a high mycobacterial loads, or if the patient is not on ART, rifabutin can be added to that backbone of macrolide and ethambutol. We also have specifically a couple of fluoroquinolones, so levofloxacin and moxifloxacin can be added to that backbone. And as a last resort, injectable aminoglycosides, specifically amikacin and streptomycin, can be added to that backbone, not other aminoglycosides. And then based on in vitro activity, if someone has refractory MAC disease, essentially bedaquiline, tedizolid, linezolid, and omadacycline could be considered. Treatment is for at least 12 months, and then patients transition to chronic maintenance therapy or secondary prophylaxis, and that should continue until the patient is asymptomatic and has completed 12 months of treatment and CD4 count is over 100 for at least 6 months. Because retinitis is the most common CMV disease, we will focus on managing CMV retinitis. The choice of therapy should be individualized based on tolerance of systemic medications, prior exposure to anti-CMV drugs, as well as on location of lesions in the eye. For example, someone who has been receiving valganciclovir, they may have developed resistance to cyclovir and valganciclovir, so they may need cidofovir or foscarnet. Now, systemic therapy, either IV or PO, systemic as opposed to intravitreous injection, has been shown to reduce CMV involvement of the contralateral eye, to reduce CMV visceral disease, as well as to improve survival. So the first line therapy includes either IV ganciclovir or PO ganciclovir. Many clinicians prefer the IV formulation when retinitis is more central and sight threatening, or when adequate GI absorption is a concern, so PO cannot be an option. On the other hand, for patients without sight-threatening lesions, oral valganciclovir alone often is adequate. Now, initially, there will be induction therapy, which would last for a minimum of 14 to 21 days, and there is a range, and that will be determined by clinical response based on ophthalmologic examination. And then this will be followed by a maintenance therapy. So during induction therapy, we give a higher doses of these, either ganciclovir or valganciclovir. So it will be higher doses during induction therapy. And then for maintenance therapy, there will be lower doses. And obviously, the primary concern with the high dose during induction therapy would be myelosuppression caused by these agents. And then the maintenance therapy will continue for 3 to 6 months until these patients, while they're taking their ART, they should be able to achieve a CD4 count of at least 100 for 3 to 6 months. And once the lesions are inactive, then maintenance therapy can be discontinued. On the other hand, if the patient's CD4 goes below 100, once somebody has developed CMV retinitis after completion of therapy, if their CD4 goes to less than 100, then chronic maintenance therapy should be reinstituted. Now, alternative therapies include IV foscarnet or IV cidofovir. It's very rare to use IV cidofovir because of the complications of dosing and managing nephrotoxicity. For patients that toxicity of ganciclovir or valganciclovir of myelosuppression is a concern, and if those patients do not have renal insufficiency, or if somebody has ganciclovir resistant CMV, for those patients, IV foscarnet may be used. Now, for patients who have sight-threatening lesions, in addition to systemic therapy, it's recommended to also add, in addition, adjunctive intravitreous weekly injections of either ganciclovir or foscarnet in order to achieve enough of the drug, adequate concentrations of the drug in the eyes. So these are the possibilities. So the preferred therapy includes either IV ganciclovir high dose twice a day, for the induction therapy of 14 to 21 days, and then switching to a lower, once a day dosing of IV ganciclovir for maintenance therapy. Alternatively, we can do just the induction therapy of IV ganciclovir and then switching to oral valganciclovir for the maintenance therapy, or for mild cases without sight-threatening lesions, the entire regimen could be oral. So twice a day dosing of oral valganciclovir for induction therapy, and then switching to once a day dosing for maintenance therapy. And at any time, regardless of which regimen is used, IV ganciclovir can be switched to oral valganciclovir as long as the patient is clinically improving and there are no concerns about GI absorption. For example, if somebody also have CMV colitis. Now, alternative therapies are listed here, foscarnet and cidofovir. You can see that, cidofovir is very, very difficult, so it's, very rarely used. It's hard to find, people who would need cidofovir, because in cases of resistance, foscarnet would be an option. Now, treatment of other complications of CMV, such as colitis, are similar to retinitis. Obviously, there will be no intravitreous injection for other CMV diseases. This concludes this presentation.